Hi everybody, it's Dr. Sloan. We're going to talk about drug therapy for the treatment of cancer. So this is basically a lecture about your prototypes for this particular material. So this is just kind of cool and fun. You don't really have to memorize this, but it's kind of interesting to know, like, how do we find chemotherapy? Where did it come from? And we found out that there were drugs, 1854, actual chemicals that could be used for different therapies. And so initially that was called chemotherapy. The thing is that now we pretty much use the term chemotherapy to mean treatment for cancer. But really chemotherapy is just a generic term. So we kind of discovered during World War II, mustard gas was used as a warfare agent, and those exposed to it had low WBC counts, and we thought, maybe diseases where we have high white counts, maybe this would be something that we could use to treat those diseases with. So started being used. By the way, prior to really any of these treatments, people with cancer just died, and there really wasn't much that we could do for them. So we've already talked about this cell cycle specific and cell cycle non-specific. And here's just kind of an interesting little chart that sort of tells you where the different classes of chemotherapies fall into. So things like antibiotics, like adriamycin, doxorubicin, those are cell cycle non-specific, meaning they kill the cell no matter what. Whereas other drugs like steroids stop growth in the G1 phase. It's just kind of an interesting thing to look at and see where these different drugs work. But again, don't need to know this really for the test. So here's the different drugs that we're going to learn about. Angiogenesis inhibitors, and bevacizumab, which we're just going to call Avastin because that's a lot easier, is our first angiogenesis inhibitor. And if you think about that, angio is vessel and genesis is the beginning, right? So the beginning of a vessel inhibitor. So it keeps blood vessels from growing. So Avastin is a monoclonal antibody, and we talked a little bit about this in class, but it is a VEGF inhibitor, vascular endothelial growth factor inhibitor, and that makes sense because vascular endothelial growth factor stimulates vascular development. And so it's often combined with other chemotherapeutic drugs and works quite well. There's a few adverse effects here. GI perforation, hemorrhage, which can be severe or fatal, wound dehiscence, which is where the wound opens up and like your insides come out, arterial thrombotic events, and then hypertensive crisis. And I'm not sure that we really understand the mechanism behind each of those things, but they've been seen, and we need to be aware of it. So probably the biggest thing with the monoclonal antibodies is you really want to watch for an infusion reaction, and you want patients to tell you, are they itchy? Are they short of breath? Are they having a hard time breathing? And then some of the other things here is a rash would be another one. Illogical thinking or edema in legs and abdomen. But really, I want you to be mostly aware of the fact that there are infusion reactions and what those might look like. Alkylating agents. So our drug that we're going to learn is Cytoxan, cyclophosphamide. It attaches to DNA and disrupts replication. So cell death occurs when the cells attempt to divide. So it kind of gets in there and monkeys around with the replication mechanisms such that the cell can't replicate. So adverse effects, it definitely causes alopecia. It can cause sterility, which many chemos can. It does cause nausea and vomiting, anorexia, diarrhea, mucositis, and stomatitis. And then on here, hematologic, thrombocytopenia, anemia, and leukopenia. And one more thing I want you to add on here, which isn't on here. I want you to add on, I want you to add on hemorrhagic cystitis. We talked about it in class, and we talked about the fact that Cytoxin is, like many chemos, processed, in the body and then excreted through the kidneys, which means that it's in the urine, it goes into the bladder, and then, out. And unfortunately, it's so toxic, its metabolites are, that when it sits in the bladder, it can cause this irritation. So I want to make sure that you put hemorrhagic cystitis on your list here. We had a question about that in our case study today. Can be toxic to heart and kidneys. So then the question would be, how would you know that the patient's having a problem? What if they start to be short of breath and they're edematous? That might tell us that maybe there's some heart damage going on. But there are tests that we can look at. We could do like an ejection fraction, which is like a cardiac, kind of like a cardiac ultrasound, but with some nuclear medicine involved, and look at how well the heart's pumping blood. And then for the kidney, we might look at things like GFR and BUN and creatinine, right? Here's our hemorrhagic cystitis. It can also cause secondary malignancies, and I want you to know that all chemo can cause cancer. How crazy is that? Not only can it cure cancer, but it can cause cancer. And so you need to know that, but this drug is a known offender for that particular possibility. So we don't often, but we do sometimes see people developing a second malignancy after they've been cured from their initial disease, and we think that this is due to cyclophosphamide. So just something to remember, that all chemotherapies can cause cancer as well as cure cancer. So that's why we're so careful wearing our PPE and being extremely careful when we administer the drug. It is a vesicant. You need to be worried about this drug if you're going to give it through a peripheral IV. Ideally, it should be given through a central line, something that where the catheter is, the tip of it is at or near the heart, so that you get lots of blood mixing. You want to monitor CBC because it causes bone marrow suppression, like most chemotherapies. Platelets, BUN, UA, creatinine. Again, we're measuring those renal pieces because it can cause kidney toxicity. Keep the patient well hydrated to decrease renal damage and bladder damage. So we would not think it unusual to give this patient a liter or two of fluid before they ever get the drug. And then there's numerous drug-drug interactions. You don't need to know that for this particular material, but it is interesting, especially with cancer, because I feel like people try a lot of alternative therapies, so something to think about. Anti-metabolites. So remember I was talking about the mole, something that kind of dresses up and pretends to be an important chemical in that DNA replication process, but then it's really a counterfeit that fools the cell and stops cell division. So the class is anti-metabolite, and the mechanism of action is this, counterfeit chemical. And for methotrexate, that's folic acid. It's a folic acid analog. Boxed warnings, so it can cause acute renal failure, bone marrow suppression, anemia, leukopenia, neutropenia, thrombocytopenia, those are all basically signs of bone marrow suppression. Potentially fatal skin reactions, diarrhea, stomatitis. So I wouldn't say that any one of these is one that you really need to pay attention to other than bone marrow suppression. Yeah. And then monitor for adverse effects. And the nadir, remember we talked about that, for this particular drug is 7 to 10 days. So if you have a patient, they've received methotrexate, and you know that their nadir is 7 to 10 days, and they call you and tell you that they have a fever, and you believe them to be in their nadir based on their schedule of chemotherapy, then you're going to need to take steps, because remember that's a medical emergency. Anti-tumor antibiotic, doxorubicin. Ooh, I wondered where this picture went. Sorry guys, let me go back. So doxorubicin, I guess I'll talk about it with that picture on top of it. Doxorubicin is an anti-neoplastic agent, which these all are. That just means against cancer, and an anti-tumor antibiotic. It inhibits DNA and RNA synthesis. It needs to be administered via central line because it is a vesicant. And you can see here, this person's had an extravasation, and they actually have tendons and ligaments visible. That's a beautiful wound, by the way. That is a lovely granulating wound bed. It looks great, all pink and actually relatively healthy, but that's going to take a long time to heal, and it's going to leave a terrible scar. So, so doxorubicin, in addition to being, aware of its vesicant nature, you want to monitor again for septicemia, which is again just infection due to bone marrow suppression. And the other thing about adriamycin is this is the drug I was telling you about that has a lifetime dose. And so you want to make sure that when you're giving this to your patient, that you know what the maximum lifetime dose is, and it's based on the patient's weight and age and sex and all that kind of stuff. And you want to make sure that before you give the medication, that's been checked and is verified. So because it causes cardiac toxicity, it can also cause arrhythmias and heart failure. It really just destroys the heart muscle. Okay, what's a vesicant? So I've already shown you this photo, and we've already talked about vesicants, but if you're going to give a vesicant, essentially you really need to have a central line. If the patient really needs to begin the therapy and a central line has not yet been placed, you want to get your very best crackerjack amazing IV starter in, and you want to get a very experienced chemo nurse who's pushed chemotherapy peripherally before to help you with this, so that we avoid having any kind of a consequence like this. This, as a nurse, I would feel so terrible if this happened. Okay, vinca alkaloids, vincristine. It is also a vesicant. It's derived from the periwinkle plant. It's a vinca alkaloid, which is kind of makes sense. It's vincristine, vinca. It blocks mitosis in the M phase. And we talked about this in class. It causes paralytic ileus. It can cause intestinal necrosis or perforation. So you really want to watch for that. This is kind of the one drug that sort of defies what we know about most chemos, which is that they cause diarrhea. This one can cause constipation, and we want to be really aware of that. And then nervous system toxicity that we talked about.